Dr. Sofia.
Good afternoon, everyone. Today I am going to present a rare case of internuclear ophthalmoplegia. So, INO is an aberrant gauge marked by an inability to adduct the affected eye, and the lesion is placed in MLF, medial longitudinal fasciculus, and pons. Most prevalent causes are ischemic CVA, demyelination from multiple sclerosis, and these two account more than 70% of INO. Coming to my case, a 61-year-old male came to our eye OPD with binocular double vision for 4 days, which was acute on onset, and vertigo for 4 days. On general examination, he was found afebrile. The heart rate and respiratory rate was within normal limits, but the blood pressure was 182 by 96, and he had no past medical history, and he was not on any blood pressure medications. Coming to the ophthalmological examination findings, his visual acuity, best corrected visual acuity in right eye was 6.9 and left eye was 6.9 parts. Pupil was round, regular, and reacting to light. On slit lamp examination, all the appendages and adnexa were within normal limits, and the lens had early lens changes, and fundus after dilatation was within normal limits. Other cranial nerves were intact. Coming to a squint evaluation, on cover-uncover test, my patient had a right eye 15-degree exo with adduction deficit of -2, which was not associated with pain on eye movement. And in the left eye, on abduction, he had nystagmus. So the etiology of double vision or diplopia according to localization can be intraaxial and extraaxial. Intraaxial are infarction, demyelination, tumor, hematoma, aneurysm, and extraaxial are oculomotor nerve palsy, which can be in subarachnoid space, cavernous sinus, and orbital apex. Coming to the investigation, all the routine blood tests were found to be normal, and on imaging, on MRI, there was infection in right medial pons. So coming to the pathophysiology, let's have a brief discussion. My patient with right eye adduction deficit on left gaze. So on left gaze, the right frontal eye field was stimulated, which sent the stimulus further to the contralateral PPRF, which then sent the stimulus in two pathways, one in the ipsilateral sixth cranial nerve and the other via MLF to the contralateral third cranial nerve. So in my patient, the right MLF was affected, so the stimulus could not go further to the right third cranial nerve. So there was adduction deficit. Coming to the management, on physician consultation, he was started on tab aspirin, atorvastatin, telmisartan, and for vertigo, he was started on betahistine. And alternate eye patching every 1 to 2 hourly has been advised. Then he was sent for neurology consultation. So to conclude, what seems harmless at first glance conceals a serious hazard. INO in hypertensive patients reiterates the need for aggressive blood pressure management to prevent further CVA. Timely diagnosis and effective treatment avert further complications. Thank you.
Thank you. Very nice case. Many cases have already been published about INO. So what is different in your case?
I'm different as such. He had no past medical history, and the blood for hypertensive, it is not so common in hypertensive cases with INO. And in diabetes and all, the INO cases are more, and most commonly it is seen in multiple sclerosis, trauma, and other like myasthenia. Sorry, these are the DDs in multiple sclerosis and trauma and.
Did you rule out these other causes?
Yes, myasthenia we ruled out, and there was no history of trauma, and like The fourth nerve palsy was not there. We also performed the Park's three-step test. It was also not present. And multiple sclerosis, it is acute, but it is usually it is in the age group of 20 to 50 year, and there was no other findings of multiple sclerosis in neuroimaging.
How did you rule out myasthenia in this case?
Ma'am, myasthenia, first there was no ptosis and there was convergence is normal in INO usually, and in myasthenia the convergence is abnormal, and it is a chronic, like gradually it develops. So, and there is a diurnal variation, but this patient didn't have any as such.
What was the MRI sequence which you have shown?
Yes.
What was the MRI sequence?
So it was a contrast, matlab, T2 contrast.
T2 contrast. So the radiologist has labeled it as an infarct.
It is a small infarct, and because his clinical in other findings were normal, so we have asked the patient to come for follow-up. He has just came once with this neuro imaging. So the radiology, as the other findings were going with the blood pressure, like ischemic, so he has been the treatment was in that streamlined to that.
It was sudden onset.
Yes, it was sudden on onset, and no past medical history was there, and he was not on any blood pressure medications.